Hello everyone, my name is Louis Kreitmann and I'm from the medical ICU of Lyon University in France. This talk is about assessing the host response to infection by transcriptomics as a diagnostic tool in sepsis. I have received speaking fees from bioMérieux, and I would like to start my presentation with a short clinical vignette. This is a general hospital in France in the year 2040. And this is Sarah. Sarah is a 50-year-old post-operative patient on the surgical floor. She develops a fever. In 3 minutes, her bedside sepsis diagnosis panel indicates that she indeed has an infection. 10 minutes later, a second test is run, the sepsis pathogen panel, indicating that she's very likely to have gram-negative bacterial infection. So she started on antibiotics. A few hours later, her clinical situation is stabilized, but a third test is run, the sepsis mortality panel, indicating that she's at high risk of developing hypotension and acute kidney injury. So even though she's stabilized, she's transferred to the ICU. Upon admission to the ICU, a fourth test is run, the sepsis endotype panel, indicating that she belongs to a subgroup of patients that's amenable to an experimental targeted therapy. So she's enrolled in a clinical trial. That's the ICU of the future. We will have fast and reliable tools, easy to use at the bedside, to 1. Diagnose sepsis as opposed to sterile inflammation, 2. Discriminate between bacterial, viral, and fungal sepsis, 3. Predict organ failures, and 4. Classify patients into endotypes. But back to 2020, what do we have for sepsis diagnosis biomarkers? By far the most studied one, actually the only one that's currently implemented in clinical sepsis guidelines, is the procalcitonin, the PCT. It is useful, we use it, it's not perfect, and some will argue it probably tells you more about disease severity than about an actual bacterial origin of sepsis. What about sepsis prognosis? Well, many biomarkers have been described, and among them HLA-DR. In 2006, a team of investigators in Lyon, led by Guillaume Moneret, studied 86 patients with septic shock. 3 to 4 days after the onset of shock, they measured the expression level of HLA-DR at the surface of monocytes by flow cytometry. And they found that a low level of HLA-DR was a strong predictor of death in the ICU, with an accuracy that was close to that of the SAPS-2 score. And that also works with the mRNA expression of several MHC class II genes. So that's good, but to use it at the bedside, you have to have a flow cytometer in your ICU, which is certainly not the case in every center. And these two markers, they're good, but they're single variate markers. And given the heterogeneity of septic patients and the complexity of sepsis physiology, it's very likely that the sepsis biomarkers of the future will have to assess not just one variable, but multiple variables of the host response at the same time. And that's where systems biology come into play. The idea here is to use a computer to analyze complex data sets on the expression of genes, proteins, metabolites. And in that respect, transcriptomics has been studied the most and has the best potential for use at the bedside. It's also very suited for multiplex, multivariate evaluation of the host response. In transcriptomics, the idea is to compare the expression of mRNA transcripts of white blood cells across different conditions and to identify molecular signatures that can discriminate between septic and non-septic patients, between different pathogens, and between different sepsis endotypes. As a first example, the septicide test is the first RNA-based diagnostic tool that's approved by the FDA for use at the bedside to discriminate septic patients from critically ill patients with non-infectious inflammation. The test combines 4 genes, 2 that are upregulated and 2 that are downregulated in septic patients. The septicide test generates a score called the septic score, with higher values of the score indicating a higher probability of sepsis. And this score was validated in several replication cohorts and showed a high accuracy with an area under the ROC curve of 0.95 and better performances than all other tests based on simple clinical and biological variables, including the PCT. A second example comes from a team from Stanford in the US, led by Tim Sweeney and Parvesh Khatri. They used publicly available data sets of septic patients to derive an 11-gene classifier with a high performance to discriminate between septic and non-septic patients. And then they came up with a second classifier using 7 genes to distinguish between bacterial and viral sepsis. Both scores are used in combination to build an antibiotic decision model that has more than 90% sensitivity for the diagnosis of bacterial sepsis. Now, transcriptomics has also been used to develop gene signatures that can split up a group of septic patients into several subgroups with distinct immune profiles and distinct prognosis, so-called endotypes. In the Mars study, unsupervised cluster analysis on 306 septic patients revealed 4 distinct clusters named Mars 1 to 4. Importantly, the 4 clusters were not distinguishable on the basis of sole clinical features. So the patients looked the same, but they had different gene expression profiles and different mortality, especially for the Mars 1 cluster that had the highest mortality. Then pathway analysis revealed that there was biological plausibility behind the clustering. The Mars 1 cluster, the one with the highest mortality, had downregulation of genes involved in both the innate and adaptive immune response, whereas the Mars 3 cluster, the one with the lowest mortality, had upregulation of genes involved in the T-cell response. In a similar study, a group from the UK used unsupervised cluster analysis on 265 patients with sepsis related to community-acquired pneumonia. They revealed 2 distinct clusters named Sepsis Response Signature, SRS1 and 2. Here again, clinical variables alone could not differentiate between clusters 1 and 2 that looked the same clinically, but had a different immune response. This picture shows in green the genes that are downregulated and in red the genes that are upregulated in SRS1 patients as compared to SRS2 patients. And for instance, when we zoom in here, we see that there is a downregulation of several HLA class 2 genes, including HLA-DR, in patients of the SRS1 cluster. And that's also the case for many genes involved in T-cell activation. And here again, patients in the SRS1 cluster had a lower survival, both in the discovery and in the validation cohort. So that makes sense. So as you can see, there have been many studies investigating the use of transcriptomics in sepsis in the last decade or so. But can we use these tools at the bedside? Almost. I've previously mentioned the septicide test, which is approved by the FDA and is marketed by a company named Immune Express. I have also presented studies conducted by Tim Sweeney. Well, he started a company named informatics, and they're currently in the process of putting out products based on gene signatures that they have identified, both in sepsis and other settings like tuberculosis. Their website advertises that their test can be used at the bedside and gives clinically meaningful results in around 30 minutes. And finally, I would like to present a product that's under development in Lyon, in France. It's called the Immune Profiling Panel, or IPP. It uses the film array technology, which is a fully automated multiplex qPCR technology that's approved by the FDA for the detection of pathogens. This system's been adapted to measure a panel of immune markers on the blood of patients, giving a simple report of expression levels in less than an hour. The panel has been tested in a cohort of healthy volunteers and in septic shock patients with different levels of HLA-DR expression on monocytes assessed by flow cytometry. And as an example here, you see the markers that are downregulated in septic shock patients, and maybe more importantly, the markers that can differentiate between septic shock patients with a normal and with a low expression of HLA-DR. So the product is still under development, but the objective is to put out a simple tool that can be used at the bedside to precisely manage ICU patients according to their immune profile. Thank you very much.